the second speaker a few words about the subject.
Dr. Shamim Akhtar completed his MBBS from Medical College of Calcutta in 2010, MD Pediatrics from Assam Medical College in 2014, and IAP Fellowship in Pediatric Intensive Care from Kanji Kamagodi Child Trust Hospital, Chennai in 2019, and followed by MT Fellowship in Pediatric and Cardiac Intensive Care from Birmingham Children's Hospital, UK in 2021. His area of interest is pediatric cardiac critical care. This words I invite Dr. Shamim Akhtar for the speech.
Thank you, sir. Thank you for the kind introduction, and thank you everybody for coming. It's not a very good season, and it's quite rainy outside, and still thank you for making time to come and join us. So I'm new to Kannur, and I think you might be wondering that what makes me somebody from Kolkata come to Kannur. The reason is my wife did her pediatric neurology fellowship from Trivandrum, so she knows, at least she claims she knows a little bit of Malayalam. So when we came back to India, we decided that if we go to Kerala, then at least only one of us will have to learn a new language. That's why, and there was an opening in Kannur, Aster. So basically, I came and joined Aster. That was since last March. So I'll skip my introduction. You've already introduced me, and I'll jump right to the topic. The question is, everybody, whether you're a pediatrician or not, you always come in contact with a sick child, whether you like it or not. If you are a pediatrician or working in an emergency department, you have made it your business to come in contact with a sick child. But even if you're not, and if you want to stay far away from the crying, whining children, I bet you still have those phone calls in the middle of the night sometimes from a relative or a colleague saying that my child has just listed a small button battery. Is it okay if I take it to the hospital tomorrow after I finish my office? So to answer these questions, we need to know how to treat, how to identify who is a sick child and how to treat. So in the beginning, let me clarify what I mean here by a sick child. Categorically, a sick child means anybody who has a physiological derangement that intermediates life is a sick child. But this is actually kind of a vague. Child with a brain tumor also has a condition which will actually at some point will endanger his life. But this is not the child I'm talking about today. So we can pay attention to the slide here, and this is basically a triad scale developed by Manchester Triad Group. And here what they have done is they have taken the common presenting complaints in the EEG and they have categorized them based on the severity of the symptoms. So if a child has an airway compromise or a drooling or is not breathing adequately or doesn't have a pulse or has an exsanguinating hemorrhage, in that case you are categorized in red. And if you are in the red category, then you need to be seen by a physician immediately, that is 0 minutes. Similarly, if you have a severe, if you have an uncontrollable hemorrhage or you are responding only to pain, then you are categorized as orange and you need to be seen within 10 minutes. And it goes on like that. So the red, orange, and the yellow category means that you need to be seen within an hour. And the reason is that if you don't intervene with these children at this point, then they are going to die. And for the purpose of this talk, these are the children I'm classifying as sick. Doesn't mean a child who has something like a dengue is not sick. It's just. Is it? I'm sorry. Okay, I'll try to do it. Thank you for that. All right. So for the purpose of the talk today, I'm classifying these children, the red, orange, and the yellow one, as a sick child. Because unless you intervene or do something meaningful here, they are going to die within the next 1 hour. The question is, why is it so urgent? So we can look at this diagram. This is the natural history of disease that we read in preventive and social medicine. So you can have when the child has an insult, and that might be anything. That might be an infection, an inflammation, a trauma, a neoplasm, or autoimmune disease. You have initial state which is subclinical. You don't have any clinical features at that point. Followed by a stage where you have a compensated state, and this is the patients which ideally see in OPD. Here, at this point, the clinical features are not much, and it's actually, if you can find out what the disease is, it's easy to treat, but it is very, very difficult to diagnose. At this point, if you're able to treat this patient, they go back to the premorbid state. But if it is not treated properly, then they go to the next stage, the decompensated stage. And at this point, the stress of the insult actually overwhelms the physiological compensation. And if you don't treat it at them, this is the decompensated state is where we find children with a hypotensive shock or respiratory failure. And if it is not intervened at this stage, the child goes into the next stage, which is organ failure, first single organ, followed by multi-organ, and then a death failure. This is this orange and the red category that we are talking about today. And these are the ideal patients we see in emergency. They are actually easy to diagnose. It's not very difficult. It's obvious that they are very sick. But at this point, if at this stage, then it's a little bit difficult to treat. So it's obvious that if you are treating with somebody who is this sick, you need an approach which will minimize the wasting of time, which will let you identify who is sick patient, which will let you identify what is making them sick, and give you easy ways how to fix it. And it should all be done. It should all be a very easy pathway to follow and to follow under pressure. So the margin of error is minimum. This is why in these cases we don't go for a etiological diagnosis. We go for ABCDE, the airway, breathing, circulation, disability, and exposure approach, and that is actually something that is validated all over the world, and that is adopted in all kinds of life supports, pediatric life support, cardiac life support, or even trauma life support. It's the same approach that we follow. It minimizes time. It lets you identify who is sick. It lets you identify what is making them sick, and it gives you clues how can you fix them. So in the PALS approach, the first step is doing an initial impression. In initial impression, you are basically looking at, I'm sorry, the slide is not very clear there. So the initial impression, what you are looking at is pediatric assessment triangle. This is a hands-off approach, and we're just trying to have an idea if this child is sick or not. So this child, so if a child who comes to you is unresponsive or not breathing well, then it's already quite late, and this child is already in failure stage, either a respiratory failure or a cardiorespiratory failure. And you might need to jump on straight away and go for a chest compression and go for artificial breathing, so that you can reverse, you can find at least some reversible cause, return of spontaneous circulation, and buy yourself some time so that you can find out what is making this child very sick. The other category is that the child might be completely, responding to you, and in which case the child might not be that sick at all, where you can go for a more stable approach, like taking the history and finding out what is actually wrong with the child. It's a third category of patient that I'm talking about today, where the child is quite toxic, but it's not into a cardiorespiratory failure already. And in that patient, we go for a primary survey. Primary survey consists of assessment of airway, breathing, circulation, disability, and exposure. So in all of this, we try to identify what is the problem. We try to categorize the children in a meaningful way that will help us stabilize what the problem is. So let me break it down a little bit more. So in airway, what we do is we look, listen, and feel. We look if the chest or abdomen is moving. We listen if there is an abnormal sound like a stridor, and we feel if there is a movement near the nostrils or not. The answer we are looking for here is the airway clear, or is it maintainable, or is it not maintainable? If it is clear, then no problem. We move on to the next step, that is breathing. If it is maintainable, means it's maintainable by some simple measures like positioning, or airway might be blocked because of some secretions or vomiting or blood in the airway, which just needs simple suction, and that might clear the airway. Or you might need a simple maneuver like a head tilt chip or a jaw thrust. Or if it is not maintainable, then you need, in that case, you need an advanced measure like an intubation. Or in some rare cases, you might need a front of neck access also. Once you have stabilized the airway, you go on to breathing. In breathing, what we want to know is this child, what we assess is the respiratory effort, the rate, the work of breathing, and the saturation. And what we want to know is how much is the work of breathing, how much energy the child is expending to maintain that saturation. Having a saturation of 100% is not enough if the child has to work very, very hard to achieve that one, because that child might fail. So the answer we want here, first place, is that is this child in respiratory distress or respiratory failure? The distinction is that in respiratory distress, the child is working hard, but still able to maintain that saturation. But even after working hard, if he is not able to maintain the saturation, then he is in respiratory failure. The distinction is important because the next step for respiratory failure, if it is not addressed at that point, and then the next step will be a respiratory arrest, followed by a cardiorespiratory arrest, which is the commonest form of cardiac arrest in children. So the difference here mainly is that in case of respiratory failure, the sensorium starts falling and the saturation starts falling. If you find somebody in respiratory distress or in respiratory failure, the first step is to give an oxygen. If the child is breathing, then you give 100% oxygen. And that can be easily done by starting the child on a non-rebreathing mask. Non-rebreathing mask with a 15 liters where the bag is inflated, that will give around 90 to 100% oxygen. And that will take care of the oxygenation issue, at least for the time being. Mind you that if the child is not breathing, then the child might be oxygenated well, but still not be ventilating the carbon dioxide out. And if the child is not breathing, then only giving an NRM, only giving 100% oxygen is not enough. That child needs a definitive airway first. But if the child has some respiratory rate, then initially you can start. The first step is to start oxygen with the NRM. After this, after you have done that one, the next step is to find out what is causing this respiratory distress, because you need that information to stabilize the child. And in PALS approach, you don't need to have a actual etiological diagnosis. You need to find out the pathophysiological diagnosis. That is, you need to find out if it is an upper airway obstruction that is causing the problem, or a lower airway obstruction, or a lung tissue disease, or a disordered control of breathing. And there are very easy tools that you can have here, very easy tools that you can look for by evaluating. Hallmark of upper airway obstruction is stridor. Stridor with a suprasternal retraction in a child who is breathing hard. In the first diagnosis is upper airway obstruction. The most common cause in upper airway obstruction in children, at least, is croup. Is either a croup or a foreign body. So to stabilize that, you need to give some. So not only oxygen, you need to give some adrenaline nebulization, and you might need to give a dexamethasone also. And if it is a foreign body, then you're suspecting a foreign body. You'll be getting more clues from the history. In that case, you need to find out if it is really a foreign body from X-ray, and you might need to go for endoscopic removal. The lower airway obstruction, the hallmark finding is wheezing. So if you have wheezing, then you go for a bronchodilation, salbutamol or ipratropium. If you have a lung tissue disease, you will get more of a bronchial sound and crepitations. Here, apart from the oxygenation, you will probably need to give some antibiotics. And if you have a disordered control of breathing, there the first three things, the main problem there is a hypoxia issue, or initially to start with at least, it's an oxygenation problem. The fourth one, the disordered control of breathing, the problem there is more of ventilation. So this child might have a completely normal lung, but might have some CNS issue which is making him apneic or hypoxic, which is not breathing well. So in a child who is actually not breathing at all, even in that child, you might be able to maintain the oxygenation by giving him oxygen, and it's called apneic oxygenation. The problem there is you might get 100% saturation, but carbon dioxide will keep on building in the body when the child is not breathing. So here you will get a pink child, we can go into cardiac arrest. It's important to recognize this. So a child who is not breathing well is very, very risky to just start him on oxygen. There you need actual ventilation, you need a proper area, and you need to start with, you need to bag ventilate this child, and then you might need to put on a ventilator. Little bit about the oxygen therapy. So most sick children that come to us need some amount of oxygen, and we can give this oxygen amount of oxygen that we can give actually varies depending on the device. You can give anywhere from 30% oxygen with a nasal cannula to around 40% oxygen in a mask, in a 100% oxygen by an NRM. And if this fails, you can go for a more of a high flow device. You can give through high flow nasal cannula, which can give 100% oxygen with a little bit of heat. It's also humidified, so it's actually quite good. You can give non-invasive ventilation, which can again provide 100% oxygenation. It provides a little bit of expiratory pressure along with the inspiratory pressure. You can give invasive, you can put the child on ventilator, which takes care, apart from giving high amount of oxygen, you can take care of the ventilation also. And even if that fails, you can go for other modes of ventilation. You can go for high frequency, you can go for nitric, or in the severe cases, or very rare cases, you can take the lung completely out of the equation, and you can do the part both oxygenation and ventilation through a mechanical pump. Why I am saying this is that children, when you are treating a child, he might start with any of this in this ladder. He might start at one level, and he might actually quickly move onto the next level. So requirement might change, and it's important that we meet the requirement of the child with the amount of oxygen we are giving. That is number one. Number two is when suppose a child who is having a hypoxic respiratory failure, we quite often we start this children on high flow nasal cannula, and with a high amount of oxygen, we are able to meet the oxygen requirement. But what we usually ignore is the amount of oxygen that is required to achieve this oxygen saturation. A child on 100% oxygen or 90% oxygen on a high flow nasal cannula is actually a very risky child, because if this child at some point fails his oxygenation, then you'll have a child who will be very, very difficult to intubate, and that child will invariably undergo a cardiac arrest when you are trying to intubate this patient. So it's important that you know that how much you can provide, how much oxygenation we can provide in your setup. It's also important, if you're using high flow cannula especially, it's also important to find out when to say this is enough, and this child, only increasing the FiO2 will not help this child, and we need to put this child on a ventilator. So regarding oxygenation, you need to find out a child, you need to recognize a child who needs escalating oxygen requirement. We need to identify our capacity to provide, safely provide increasing amount of oxygen. We need to take into account the oxygen required and the pressure required to maintain the SpO2. And we must not forget ventilation. Only giving oxygen, again, a pink child might go into cardiac arrest. He might be 100% oxygenated and still might go into cardiac arrest. So next is circulation, and what we look here is heart rate, heart rhythm, the pulse volume, the blood pressure, the capillary refill time, and the skin. So the mottling of the skin that we look at. The first category we want to categorize these children is it a compensated shock or a hypotensive shock? So compensated shock, this is actually very important in children, because children are able to compensate their blood pressure till a very long time by increasing their heart rate. So child in a compensated shock will actually be in shock. The tissue perfusion will be suffering, but the blood pressure might still be maintained. Heart rate will actually be very high. It's important to identify these children at this point, because the next step is a hypotensive shock. If you find a child who is already hypotensive, it's still a bit late in the game. So if you find a child who is in shock, the first step is to give volume. Even if it's a cardiogenic shock, I would say the first step would be to give a volume, 10 ml per kg. At least you need to give. But the next step is you cannot keep on giving more volume. So you need to find out what is the pathophysiology that is causing this shock. It might be hypovolemic, obstructive, distributive, or a cardiogenic. And the treatment of each of these is actually very, very different. So in a hypovolemic shock, we give more and more volume. But if you give a lot of volume in a child which is a cardiogenic shock, only the volume is going to make it more and more worse. So when you are treating a child with shock, it is very important that very early in your treatment, you have some idea regarding what kind of shock you are treating. So if you see the PALS algorithm, they have given some ideas of the clinical features that you see in different kind of shock. But frankly speaking, this doesn't help a lot regarding differentiating how you find out what kind of shock you are dealing with. The only sensitive clinical pointer here I found was the pulse pressure. In a septic shock or in a distributive shock, the absolute pressure will be low. The pulse pressure will be quite high. In case of a hypovolemic shock, like a dengue, the diastolic pressure might be quite high and the pulse pressure will be narrow. But apart from that, it's actually quite difficult to say what kind of shock you are actually treating, because you will always have a long capillary refill, tachycardia, and a hypotension. The clues here, so in this case, we actually need to take a history, and a very brief history can also give you clues regarding what kind of shock you are treating. If a child is coming with multiple episodes of vomiting, diarrhea, or a trauma which is causing bleed, that is probably a hypovolemic shock. Child with a fever for a few days with some focus, and now coming with a reduced perfusion, that is probably a septic shock you are dealing with. Similarly, a child who has a large liver to start with and palpitations, if that child is in shock, you will be very worried. You'll be probably not giving more of a volume before you have a definitive identification. Here, when you are dealing with a child in shock, the most common one that we deal with is usually a septic shock. The septic shock algorithm is given by American College of Critical Care Medicine, and they say you can give 60 ml per kg of volume, followed by, if the child doesn't respond to that, you start an inotrope, and if the child doesn't respond to that, you can categorize as catecholamine resistance and you go for steroid. The thing is, this doesn't work in all the cases. So you consider if you want to give 60 ml per kg in a child who is say a dengue child or a dilated cardiomyopathy, that is going to be disastrous. So a more rational approach is, after giving around 20 to 30 ml per kg, you should think of getting an echocardiography at that point. Echocardiography actually helps in a lot of ways. You don't need to be you don't need to be a cardiologist to do this echocardiography. You just need to put a probe on the heart, and basic functional echo will tell you if this child has a good contractility and it's a small volume lung, and how is the IBC that is how is the IBC. So if it is a contractility is poor, then it is probably a cardiogenic shock, and with a enlarged liver and a fibrillation that will confirm your diagnosis. In that case, just after 10 ml per kg, probably you will have to go for adrenaline or inotrope. But if it is a child who has a very collapsed IBC, small volume lung with a kissing ventricles, then probably you are dealing with a metabolic shock, and you have scope to give more volume. In case of septic shock, it's a bit of everything. So you have the vasodilation, and you have a cardiogenic component also. There is always a myocardial component also. So in case of cardiac, that is why in case of septic shock, initially we keep on filling up the child, but after that, you need to start on some inotropes. One important thing to remember here is if you are treating with children, you are dealing with children, then it's even in the case of shock, you need to see how much is what is the PCV. A high PCV with a low platelet, any child with shock, you should be thinking about dengue. The fluid management in dengue is quite different from the way we treat a septic shock. So that needs to be in your consideration quite early. These for disability, what we look for is the sensorium by Glasgow Coma scale or ABQ scale. Look at pupil, posture, and dexterous. Now, what CALS tells us, if there is altered sensorium, we probably need to look at airway, breathing, and circulation again. The reason is very simple. If you see the most common cause of altered sensorium in children, it is usually either a poor cerebral perfusion or an infection. And if the child is hypoxic or hypotensive, it's only going to add to the brain insult. So it makes sense actually to address this, the A, B, and C again in these cases. But there is one condition, there is one condition in children or in any patient as such, where you need to address the brain issue separately. That is raised intracranial pressure. If a child has a raised intracranial pressure due to trauma or a decay, then that is actually an emergency, and that needs to be addressed immediately. And it cannot only be done by, yes, ABC is important, but at that point, you need to immediately give a 3% saline or a mannitol. You need to intubate this patient, hyperventilate, to bring the carbon dioxide down, and you need to get an urgent CT. I had one of these patients once who had an earlier diagnosis of brain tumor and came in kind of low blood pressure, unequal pupils. This was early days in my fellowship. And because the blood pressure was low, we tried to fix the blood pressure first. The pupil was quite unequal, and we took a long time before we could get a CT. By the time we had stabilized the blood pressure and we had got a CT, the pupil was actually very unequal and it was non-reactive. And the child had already gone. So there, later when we reflected on it, we had a child who had a good lung and a good blood pressure now with a central line and an arterial line and a good blood pressure, but a child who had fixed dilated pupils and was brain dead. So we need to prioritize brain in these situations and need to know that what needs to come early. Never underestimate unequal pupils. That is one thing that we always need to see. The other thing D is dextrose. In all sick children, we need to see dextrose. I'll give a few examples later just to illustrate my point there. E is exposure. This is where we look at skin. We need to see if there is any rash. If there is any rash, what does it lead to? If there is any external bleeding, especially in trauma cases where we need to control the bleeding, we need to see the temperature. The children might be very hot or very cold. We need to treat appropriately, or if there is any other obvious abnormality. So once we go through our primary survey and we have kind of stabilized, we need to go for a little bit more information. So that's why we need the secondary survey. Secondary survey is basically focused history and focused general examination. We don't go for detailed history. We just need to find out what are the signs and symptoms, allergy, any medications, any past history, the last meal taken, because that might be valuable information for intubation, and what are the events leading up to this. And we do a very quick focused examination, top to bottom examination. Diagnostic test is depending on what kind of condition we are treating with. But in my experience, if you can do only one test, it's always better if you can get a blood gas. So blood gas, irrespective of it is a capillary or arterial or venous, if you have a blood gas, then you at the same time you have oxygen and PaO2, you have PaCO2, which tells you the oxygenation status and the ventilation status. You have bicarbonate and lactate, which will tell you the perfusion status. You have hemoglobin, which is a very valuable indicator here. you also have the electrolytes, the sodium, potassium, and calcium in those gases. So that will also that will tell you if you need to treat something urgent. The other thing is the blood glucose. If you don't work in a setup where you can get the, and the most important thing with the VB is that you can get it immediately. A child who is sick and desperately suffering, you have the information immediately at your hand. It just prevents you from wasting time. So stabilization will actually depend on each patient, and as I told you, it has to be tailor-made. It has to be fine-tuned with each patient. But there are a few guiding principles which usually help in all patients. First thing is that what we stabilize or what we can stabilize is basically A, B, C, D, E, and some critical lab values. In some cases, that might be definitive, and in some cases, that itself might not be a life-saving treatment. Consider a child who has an internal bleeding. You might be able to stabilize, you might intubate, you might ventilate that patient, and you might give blood products and inotropes to stabilize. But unless you take control of the bleeding, the child is going to die. So while stabilizing, you should not lose the idea of what actually you are trying to stabilize, and actually if it can be stabilized at all. We always need a pathophysiological diagnosis or working diagnosis and appropriate test. We might not get the actual diagnosis or etiological diagnosis, but having a working pathophysiological diagnosis is very important. We need to find out what are our goals and what are our achievable goals, especially. We need to find out if we need to consult in specialty and we need to get it immediately. Suppose a child with internal bleeding, you need to get a surgeon on board immediately. If that internal bleeding is not stopped, despite all your efforts, the child might die. We need to know what is the limitation in our settings, how much can we provide, and what will be the time where we send to some other centers. We need to know where are the suitable referral centers that can provide more of treatment, and we need to know what is our transport. And it's important to have a pre-decided referral criteria, because working in real time that can be quite problematic. At the end of the day, if you are trying to stabilize the patient, at some point you are going to face this question: how much to stabilize, and when are we good? At what point we say enough is enough? I can't treat this child anymore. This child needs to do some other somewhere. In my experience, stabilization is more of a decision-making challenge rather than being a technical challenge. You might be technically very well equipped, and you might be able to provide everything for a child, but it's important to find out if you have the adequate team or resources to treat that patient. What I do is, in this situation, I ask myself, do I have the resources and do I have the team to manage the child here? And if this child deteriorates further, what will be when next move? Will I be able to manage this child here? If the answer is yes, then the strategy we adopt here is stay and play. You stick to your guns and keep treating the child. But if the answer is no, then probably what you need to do is you need to refer this child early, before the child is in a condition where it is too sick to be even transferred. So I have a few case scenarios which I'll discuss, so that I think that those will consolidate what I have just said. But before going to that, just a small caveat. The whole of PALS algorithm and the PALS approach is based on the fact that children are able to respond to the stress. If they have a pneumonia, they will be able to respond. They will be showing some respiratory distress, but that might not be the case always. Consider a child with a spinal muscle atrophy or any other neuromuscular disorder. That child might be desperately sick and have a big pneumonia and ARDS, but still will not have respiratory distress, because this child doesn't have a muscle power to produce that kind of respiratory effort. So be very careful while dealing with this patient. Similarly, a child who is on immunosuppressive, this immunosuppressed patient might have a fever, might have an infection, might be septic, but might never show a fever spike. So any child who has a premorbid condition or a chronic disease is actually past that compensated stage, and it's already in the decompensated stage. And we need to be very careful. And these traditional ways with which we find the sick patient or identify a sick patient might not be working there. Same thing applies to a very small kid, especially who is less than 6 months. This children might be desperately sick. And there are a few other conditions where the child might be very sick very soon. So the initial phase where they are stable, subclinical, and show some mild features, that might not be there at all. So consider a child with a poisoning. A child who has ingested some rat poison might come to you and might be giggling and might be smiling and might look perfectly okay. But that child, if the child has ingested enough amount of poison, say a rat poison, the child is going to be deteriorating very quickly, and those children should be cared for only in referral centers or a center that is that have the capacity to support the organs. Same thing applies for a button battery injection or a magnet injection or a burn patient with a brain injection. They can deteriorate very rapidly. So I'll finish with a few case scenarios. These are all real life scenarios, and let's see. So first this is a child, a 4-year-old child from District General Hospital, and they called us saying this child is a fever and has a stridor and is drowsy. So we asked what is making this child, what is the cause of the stridor, and they said this child has a submandibular swelling. So when we went there, this child was drowsy, had a huge submandibular swelling, was a bull neck. The referral center where we wanted to refer there was around 1 hour away. The question here is, should we scoop and run, or should we stay and intubate this child and then transfer? What we had to consider is, this child, if the airway collapses completely, would I be able to intubate this child on the back of ambulance? The answer was no. This child is an anatomically difficult airway, and that is something that we cannot probably do in the back of an ambulance. So we decided to stay and play here. We called up the anesthetist, and the anesthetist actually intubated this child with a video laryngoscope, and it was a grade 4 airway. So quite difficult even for an anesthetist. So consider, just imagine if we had taken this child on an ambulance and the child had deteriorated and collapsed the airway on the way. There was no way we could have intubated this patient, and this patient would have died there. So the lesson here is, impending airway collapse needs addressing before shifting. And here we basically are stabilizing for transport. Putting the tube in is not the end game for this child. After we put the tube in, the child had to had a CT, found the abscess, had injection and drainage, and that will go. But here we had to stabilize the airway just to get the transport done. Okay. Next one, this is a 3-year-old child, fever, drowsy, and a low volume pulse, septic shock. When we reached there, the child was desaturating and was already hypotensive. Question is, should we stay and stabilize everything, or should we just scoop and run and let the next hospital take care? Our decision was that this child is in respiratory failure and hypotensive shock, and the next stage for this child is a cardiac arrest. So we need to stabilize it. We intubated this child. We gave volume doses. We started the inotrops. We gave the first dose of inotrops. We got some saturation improved, and we got the blood pressure just stable enough to transport. At that point, we transported. Child was treated and was actually was discharged. Okay, this is a month back probably. This is a 10-year-old with ITP. Had a this cycle handlebar injury in the abdomen in the evening. Did a CT angio, but there was no obvious bleeding inside the abdomen. But we still, because this child had a premorbid condition, the ITP, we admitted this patient. So when he got the CBC back, the platelet was 10,000, and within next few hours, the hemoglobin dropped from 10 to 7, and the abdomen started distending. Now we give multiple blood products. We put him on a massive transfusion protocol. We gave platelet, and we actually gave multiple blood products, and the blood pressure was kind of stabilized. But the question is, would a child who is having who is dropping the hemoglobin despite giving blood products, is this child stable enough? And is only a medical management going to stabilize this patient? Our decision was no, that is not going to be the case. So we made this child stable enough to go for surgery. So we transfused the platelet up to 75,000. We gave FFP to normalize the PTA-PDT. We transfused the hemoglobin to 9, and we had a good blood pressure. And we called the surgeon and said that this is the window where we need to go in, where we need to do a laparotomy, stop the bleeding from inside. And then, and this child right now is stable enough for surgery, but we might not be later. So he agreed with that, and he went for a laparotomy, and inside there was quite diffuse oozing. Cauterized all the points and came out, and this child was actually quite stable after. Okay, these are the two similar patients, but very bad, very different outcomes. First one is both are newborns, both are pulmonary hypertension with increasing oxygen requirement. The first one, the consultant calls us and tells us this child is on high frequency ventilation. We are on 100% oxygen. When we go there to retrieve the child, this child is already on inotrops. Now, we did not have, so this child is basically on high frequency ventilation on 100% oxygen and some inotrops. But on the transport ventilator cannot give high frequency oxygen, it can give only conventional ventilation. So this child is, when we tried to shift this patient to our transport ventilator, every time we tried that, this child started desaturating. This child was so sick that we could not transfer him from high frequency to conventional ventilation. The ECMO center, this child probably needed an ECLS, ECMO, and the ECMO center is around 30 to 40 minutes away. But we could not stabilize him. We could not transport, we could not stabilize him enough for a transport. So this child ultimately had a cardiac arrest and died. Contrast this with this next child, another PPHN, and the consultant calls us and tells us, I have a child with a PPHN. The FiO2 right now is 80% and increasing, and I'm worried about this child. We went there, we put the child on conventional ventilation with 100% oxygen and shifted to the ECMO center. We started on high frequency ventilation, we started on night. The child actually improved with that and did not require the ECS. So you can see the timely referral makes a lot of difference. If you are treating a child and if you have maximized your capacity and you've maximized your capacity already and you don't have a way to transport this child to a higher center, then it's already lost. That team is already lost there. So timely referral is very, very important. And deciding beforehand at what point do I refer this patient becomes very, very important. I don't think the consultant in the first place was actually delaying it, but we can get caught up in things while stabilizing a patient, and saturation and oxygen requirement might just go up increasing very, very slowly. But if you don't have a pre-decided criteria at what point I'm going to transfer this patient, you might be transferring them too late. Okay, so this is the point I wanted to make regarding blood glucose. Two patients, both of them here treated in Kannur. So first one, this is a 10-year-old child, previously normal, went to school, was feeling uneasy for a couple of days, became unconscious in the school. Went to a hospital, no cause for syncope was found and was sent home. This child gradually deteriorated over the next 36 hours and then came to our hospital after 36 hours in the night. On admission, the blood sugar was around 1200. Child was anuric, child was hypotensive, ketone bodies in the urine, ketone bodies in the blood, and child was not responding to pain. So this was a DKA in shock in a cerebral edema. The mortality in DKA is around 1%. If you add DKA with a cerebral edema, the mortality goes to 40%. If you add DKA with cerebral edema in shock and renal failure, the mortality is 95%. This child had a cardiac arrest, and we could not resuscitate this child. Contrast this to the second patient. This patient is 11-year-old. This is a post-bone marrow transplant for a Fanconi and was admitted, was feeling uneasy, same kind of symptom, was feeling uneasy. I did not think this child has a hyperglycemia, but we did a BBG as we do in all sick patients. Because as I told you, it can give a very, very quickly a lot of important information. The blood sugar in the BBG was completely incidental finding. Blood sugar in the BBG was 560. So we did an HbA1c, it was 9. This child was post-bone marrow transplant. This child was on a lot of steroids, so that was probably causing the hyperglycemia, and this child had become diabetic. Now consider this was an incidental finding. The child was not very sick. We can give a little bit of insulin, and the child was discharged. If this child had not been picked up, and this child developed a blood sugar that is going up 800, 900, and came to us in a ketoacidotic state, this child would have had a disastrous end. Blood glucose is quite easy to do. It costs around 150 to 170 rupees. All the children that are coming to ED, sick patients, you won't have a hyperglycemia, maybe 1 in 1,000, maybe 1 in 10,000. But in that patient, that 170 rupees is probably going to save that. So I would suggest that in all sick patients who is coming to ED should have a blood glucose. Okay, and this is the last case, I think. So this is a child who had antenatally diagnosed transposition of great arteries with an intact septum. So the blood from the body is not going to the lungs, and blood from the lungs is not going to the body. And so it's a CTVS emergency. Here, the question is, this child, we are expecting this child to be born too. This child was born with a saturation of 50%. So the question is, do we intubate, do we give some more ventilation, and we try to stabilize this patient? The answer is, this patient cannot be stabilized. The stabilization method for this patient is having a balloon septostomy. Without that, you cannot increase the oxygen. So it doesn't matter if the saturation is 30%, doesn't matter if the saturation is 20%. You just need to swoop and run in this case. That is what we did. We planned beforehand. As soon as immediately after birth, this child was intubated by the neonatologist. We were waiting outside the outside the theater. We took the patient, we put him on prostine, and we just took him straight to the theater. The cardiologist confirmed the diagnosis there, and the child immediately had a atrial septostomy. Saturation improved from 50 to around 70%. That is actually what we could get. And then a couple of days later, this child had an arterial switch. and was okay after that. So here the point is there are some situations which we cannot stabilize medically. Surgery is the treatment there. That distinction needs to be made. That decision needs to be made that if we delay here, we are only wasting time. And in those cases, scoop and run is the only possible decision that should be made. So to conclude, treating a sick patient is once you come in contact with a sick patient, it is a ticking time bomb. And if this bomb is not diffused in timely manner, it is going to explode. So be very careful while treating a sick child. Follow the PALS protocol. It is validated. It works. It is easy to remember, easy to follow, and it gives you how to stabilize a patient. Follow the evaluate, identify, intervene cycle. While stabilization, you keep in mind what is your goal, what can be stabilized and what cannot be stabilized. Decide on your strategy. Do you have the resources to stay and play, or you don't have, where you need to just scoop and run? And last thing is decide beforehand what is going to be a criteria for referral and referral. Thank you. Any questions? I'm ready to answer.
Thank you, Dr. The excellent and very important talk on the six identification and management. The topic is
AAP.
That is what, sir. But that child might not be that only increase in temperature. Sorry. So only increase in temperature or if that is what that toxic, you can still go for this pathway. What happens if the is saturation, the blood pressure is saturation is maintained, the air is maintained, and if it is maintained, it is also maintained. Then the man what they can hit is but if the child has very large, is not integrated, then you must stabilize the blood pressure is going to go down. Stabilize the saturation, and then you take a decision what is possible for the people during the course. What I explain to this that's the kind of studying for source. So for the pediatrician, there is another pediatrician. Around these I can see the patterns are not possible. But this is not patient, and like actually and they are so the problem is much more difficult. And I agree that the balance part, sometimes critical balance is even more and essentially their process and we have what is actually the balance.
You cannot expect selecting normal. And any video science cannot do anything. In spite of that, the entire brain of the what diagnosis or what asking the silly उसकी कोई not apply. इसे आपने कोई किसी और काम नहीं not come. But ये इस पे आया तो expect already lost. ये से तेरा सिंह जाएगा. Now we are here to know what is it because we are not in our hands diagnose or video के और बहुत ज़्यादा ट्रेन और बहुत ज़्यादा चिंता situation that are either made the college to diagnose out of us. But we use it to see. So like that, I think happens legally because it's so fun. And now people will take everything. You are waiting for that. I think better we have to I think most stress to be given doctor and we are recently taking acid the program.
Here's the problem that in when you get this, for example, the resistance passes to that approach, that doesn't affect the signature. It's actually part of the curriculum. We concentrate for just to learn that. Actually, legal cases we need to have a legal identity. Legal part. This type of intelligence. So,
We, Kannur IMA, express our sincere thanks to Dr. Shamim Akhtar for his excellent and sincere, for his excellent speak on identification of a sick child. Thank you, Doctor. And I thank all members of the Kannur IMA for attending this meeting. Thank you.
It's closed for dinner.